Okay, good evening, everyone. Welcome to our first seminar, Myeloma 101. We are very happy that you could join us tonight. My name is Lydia, and I am the administrator at CMRG. As guest speakers tonight, we'll have Dr. Donna Reece and Suzanne Rowland, a nurse practitioner. In the next minute, Dr. Reece and Suzanne will start presenting their slides. And then in the last 50 minutes, we'll take a few questions. We'll try to answer as many as we can. If we are not able to answer all of the questions, you can always email them to me at my email contact@cmrg.ca.
So I'll take it from here and begin by expressing my pleasure at being able to kick off this series. Next slide, please. The original goal, next slide, please, was to provide an update for all the research that's going on in myeloma, but that's quite a complex topic. So since we anticipated our listeners would be with various levels of familiarity with myeloma, we thought we'd start at the very beginning and then work towards some of the more complicated issues. So our overall goals of the series are to provide both a scientific and a patient-oriented perspective of myeloma features and biology. And because the patient-oriented part is so important, we're really happy to have Suzanne Rowland, who was our nurse practitioner for myeloma at Princess Margaret for many years. And although she started with the palliative type practice, became very apparent early on that newly diagnosed patients had a great deal of symptoms and needs. And she worked with us so that our patients, instead of just reporting into a healthcare provider once a month at our doctor's visits, she saw them when they came in every week, for instance, for a Velcade injection, and could deal with those problems without having to wait in our rather busy clinics. We also want to set the stage for other presentations in this series, provide information about the newer treatments and how they're doing better, and then a framework for discussing this whole new world of immunotherapy, and in particular, how our patients can access them, because they're expensive and we don't know when they're going to be funded, and there's a mishmash of trials and access programs that we see on the horizon. And we do want to provide a forum for our participants to ask questions.
Thank you so much, Dr. Reece. I'm really, really very excited to come on to the team volunteering my time now that I've retired from my full-time gig as a nurse practitioner. I enjoyed my time at Princess Margaret, although sometimes quite challenging. And again, I'm so excited to learn more about CMRG. Every day I'm learning more about the importance of clinical trials and what CMRG is undertaking. So I want to thank the team at CMRG for taking me on and allowing me to come on and maybe help with some education, especially around the not so medical piece surrounding a myeloma diagnosis, but the things, psychosocial things and you know, things that maybe just, as you said, you don't have time in clinic visits to address. So thank you very much to you and your team.
Well, we're delighted that you've chosen to spend some time with us. Next slide, please. So I'm starting out with some of the scientific part, and I realize that many of our listeners will be quite familiar with this, but I think it does help to start at the beginning. What is myeloma? It's a cancerous proliferation of these specialized cells in the bone marrow called plasma cells. And their job normally is to make an antibody. And when they overgrow, most of our patients release into the bloodstream an intact or a whole monoclonal antibody, or what I've nicknamed a half an antibody, which is a light chain. And we use this as a tumor marker. It usually doesn't cause harm, but it is how we monitor the disease. I think you're all aware that this disease is more common than many realize, and that it is in general an illness of older individuals, but we certainly see younger patients. My youngest patient was 27 years old, and survival has improved. I've been at Princess Margaret 22 years, and I still have patients I saw in September 2001 that are still living and doing well today. But cure has been challenging. Next slide, please. Now, what happens in the bone marrow in myeloma? On the left, you can see these fairly bland-looking cells, and there is a stem cell that you might think of as the granddaddy cell. It gives rise to all the blood elements. You may recognize these from your blood test: our red cells, our white cells, our platelets. Next slide. And normally, less than 5% of all the marrow cells are plasma cells, and each one makes a different type of antibody because we need to have those antibodies adhere to and help destroy all the invaders. We have bacteria or viruses. Next slide, please. Now, in myeloma, too many plasma cells accumulate in the bone marrow. Next slide. And we have definitions that those plasma cells, when they're at least 10%, we can say they're myeloma. That doesn't always mean they're misbehaving and causing damage, but that is how we classify this disease. Next slide, please. Now, this cartoon is supposed to represent what happens when these dark blue cells with the purple nucleus overtake the bone marrow. They are still most of the time producing an antibody into the bloodstream, and you can visualize how those cells might crowd out the precursors that make particularly red cells, sometimes white cells and platelets. Next slide, please. And in general, the more myeloma cells in the marrow, the more monoclonal antibody levels in the blood. So we can use this as a tumor marker. There's that correlation. But as I'll talk about later, myeloma can be sneaky. And we're going to talk about some of the ways it can be challenging, so that you're aware of why certain tests are done and how this disease can be different in different situations. Next slide, please.
I'll jump in there just for a second. Now, I know many people in our virtual audience this evening are very knowledgeable about multiple myeloma. When I first joined the team, the old saying, fake it till you make it, was in certainly what I was doing. I had come from quite a long career, primarily in palliative care, and my oncology experience was certainly in solid tumor, most of the time in GIGU cancers. So I'm hired onto this wonderful team, and I set out to create this new role, and I quickly realized I had no idea what I was talking about, and I was feeling really inadequate. And I came across this video. We're not able to put the link up because it is a YouTube video, but if you go on YouTube and just put in the origin of the myeloma cell into the search engine, this is a video that was done by Myeloma UK. It's very simple. And as anybody in the audience that knows me knows, that I always work by the KISS principle, which is keep it simple, stupid. And it really helped me understand what was happening with the patient and their disease. I was quite shocked. Many patients that would come to see me later on in their disease trajectory, sometimes 5, 6, 7, 10 years after diagnosis. And I was quite shocked that many of them really didn't have a good understanding of what multiple myeloma was. So I encourage them to take a look at this video, watch it a couple of times. When friends and foe and family are asking, well, what, you say you have bone cancer and all of these things that people sort of misunderstand, and and say, get them to watch this video so that they might understand. So I highly recommend it. I highly recommend it for children in the family, grandchildren, although most of them are smarter than we are, let's face it. But please, if you have a chance to take a look at this, you might find it really helpful, if not for yourself, but for some of your loved ones. Thanks, Dr. Reece.
Next slide.
Dr. Reece is going to talk more scientifically about antibody types, kappa, lambda, monoclonal protein, immunoglobulins, etc. I wanted just before Dr. Reece speaks to them, a common question that I would get for patients that I was seeing in our malignant hematology day unit was, I was in the waiting room and I was talking to this other guy, and he's got myeloma and he's got an IgG kappa, and I've got an IgA lambda, and does that mean that his disease is better or worse, or does he get different treatment, etc. I think it's very, very important that myeloma patients and their loved ones understand that regardless of whether the patient has a light chain or not, or a heavy chain or not, or if it's a kappa or a lambda, none of those things are pertinent to either treatment or prognosis. And one of the things, and I'll talk a little bit tonight, but certainly more in future seminars about, people really, 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 this is a very stressful disease, as many of you know, and anything that we can sort of push to the side and make it one less thing to worry about is important. So whether you're a kappa or a lambda, if you have a monoclonal protein or not, it's really, really not going to affect treatment or prognosis. Thanks, Dr. Reece.
Yeah, and thank you. And I would just add too, how many plasma cells there are in the bone marrow, how many myeloma cells is not the critical prognostic factor. And that's different from other cancers. If someone has colon cancer, if it's a big lump, it's worse than it's a little lump. The key is in the biology. Is it going to sit there and cause not much harm, or is it going to grow quickly? So the typical way we think of a cancer is not as relevant for myeloma. And we'll try to, at later talks, talk more about the whole idea of risk, high risk, standard risk, which is, in my mind, a very imperfect science at this point. Next slide, please. It's easier, though, to talk about this antibody structure. So I have some cartoons to show that there's a plasma cell. One plasma cell makes one kind of antibody. It makes a heavy chain and it makes a smaller light chain. It makes them separately. They've got to find each other in the cell, get stuck together, and then they're secreted out into the bloodstream. And what gives them their ability to recognize all the different germs are the blue parts. The plasma cell picks those blue ends that is the best fit for the invader. So our plasma cells in our bone marrow are busy making all sorts of antibodies to keep us healthy. Now, having said that, having a lot of infections does not lead to myeloma. But there are other factors. But again, I think the other point is a plasma cell does not change what kind of antibody it makes in terms of going from IgA to IgG or to IgM. It can change, I'll talk about that in a minute, but it doesn't go to another, what we call isotype. Next slide, please. Now, this again is to illustrate what happens in the diseases of the myeloma family. I've talked about how normally we have scattered throughout our bone marrow all these plasma cells, and this is color coded. So the green cell makes a green antibody, the maroon one makes a maroon antibody. But in these plasma cell disorders, one guy, and here it's the mustard colored one, takes over and grows more than the others and becomes what we call a clone. And of course, in the usual instance, it's still trying to do what it was programmed to do. It's still making the mustard colored antibody, and it makes it to excess. And that's why it can be used as a tumor marker. Next slide, please. Now, the patterns of this type of antibody or immunoglobulin production can differ in different patients with myeloma. The majority of patients, 80%, their plasma cells, when cancerous, are still making the heavy chain and the light chain and getting the whole antibody out into the bloodstream. But it's important to realize that all plasma cells, healthy and cancerous, always make more little light chains than heavy chains, so that we always have some free light chains in our circulation. It's just so the little guy can pair up with the big guy, and I've got to find them and go out in the bloodstream. That's why we measure both at diagnosis and tend to follow both throughout the disease course. However, 15 to 20% of patients, their myeloma cells have become abnormal, dysregulated, and they've forgotten how to make the heavy chain. So they just make the light chain. And since we measure it a different way from the whole antibody, we have to do different tests. And then there are the small proportion of people who have myeloma cells that have forgotten how to make both the heavy and the light chain. This is so-called non-secretory. And in this case, we have to follow a bone marrow biopsy in some patients. However, with the newer free light chain assay, most of these so-called non-secretory myelomas still get out a little bit of light chain that we can pick up with the blood test, the free light chain assay. So fortunately, we don't have to rely on serial bone marrow biopsies to monitor the disease in most instances. Again, as Suzanne said, it doesn't affect treatment or prognosis to have these different secretory patterns. It affects how we monitor the disease.
And I guess really important to really understand, if we can just go back one slide, Lydia, thank you, is that these markers, a lot of times patients would be concerned about, what the free light chain was doing, et cetera, et cetera. And I would just explain that the free light chain is something, these markers we use in myeloma the same way that a urologist would use a PSA for a gentleman with a prostate cancer or even an enlarged prostate. It's just a way of keeping track of the disease, and so it's really not something, an additional burden for patients to worry about. We're just using the light chain as just one tool to sort of understand what is happening with the disease. And in one of our future talks, we're going to be talking about interpretation of tests, both imaging and blood tests, to have a better understanding of what it is that we should be more concerned of. But I think that the light chain, just if you think about it, it's no more interesting than the annual PSA that gentlemen get done if they have a history of prostate cancer.
And one of the reasons is we're not, in general, measuring one lump. We're measuring these tumor cells, if you will, that are spread out inside our entire skeleton. How do you measure that? Yeah. We do have some imaging, but we can't follow a lump that gets bigger and smaller. Next slide, please. So the main problems with myeloma, this audience will be familiar with. The majority of people have low red blood. I've already alluded to that a bit. Anemia, I tend to say the gas tank is low, people are fatigued. And this unusual kind of bone damage where the myeloma cells in the bone marrow dissolve the bony casing, the skeleton, the cortex, from the inside out. On the images, it looks like holes in the bones, but they're thin areas. They can hurt and they can predispose to fracture. We'll talk a bit about infection risk. And, we've said a great deal that the myeloma antibody marker or light chain is mostly a tumor marker. It can, in a minority of patients, cause problems because light chains can clog up the kidneys. So a minority of people have decreased kidney function from the myeloma product, not so much the cells in the bone marrow. Next slide, please.
This is a slide that I took from one of my old slide decks that I used to present, and I reviewed it with Dr. Reece not too long ago, and I understand that things really haven't changed much. The majority of multiple myeloma is diagnosed accidentally, and this will be either a patient will go into their family physician for an annual physical, which of course during the pandemic was very, very difficult and people are quite behind. Or they'll end up in the emergency department with sudden onset of pain, and it'll turn out that they actually have got to have a fracture. This is all related to, these fractures are related to these lytic lesions. And as Dr. Reece mentioned, the bone becomes very thin. And in actual fact, you know, when I look at pictures, it almost looks like a really, really good piece of Swiss cheese where everything's very, very thin in spots, and then it'll be attached in other spots. And the two little pictures on the screen, the one at the top is of a patient with myeloma. They have had lytic lesions in their skull. We generally don't do anything for these lesions except in extreme situations in the skull. But the darker areas on the skeleton below the skull, those really dark areas in the rib cage and in the scapula, the shoulders, and you can see at the top of the femurs or the thigh bones, those are all lytic lesions. So those are potential fractures. And again, at another talk, we'll talk about how we manage those things that are potentially going to fracture. When patients are often diagnosed with myeloma, in retrospect, either the patient or the patient's spouse or partner or the family physician will say, yeah, you know, you've had a lot of infections over the last year, and everything sort of gets put together. You know, suddenly this patient presents and they're a bit anemic and they've had lots of infections, and now they've got a suspicious looking spot on a plain film. So that's how often patients will come to a diagnosis. One of the things that I was chatted about with many patients over the time I was with the team was the frustrations about getting a diagnosis, and that, you know, I would hear, I went to my family doctor, you know, 4 or 5, 10 times, however many, you know, because my back hurt and I was feeling really tired, and the frustration was obvious when then all of a sudden I'm in the emergency department and my kidneys aren't working very well, and I've got a fracture in my spine, and all you know what is breaking loose. And I'd be interested, Dr. Reece, to sort of understand what your thoughts are, or maybe I'm barking up the wrong tree, and maybe these were just patients that happen to be chatting with me. But it seems to me that often it seems to take quite a bit of time often for patients to come up with a diagnosis of myeloma, even if they've had these vague symptoms for sometimes a couple of years.
Yeah, I think it's still a problem, and it's multifactorial. Back pain and fatigue are extremely common in the population. Also, the tests that are ordered for myeloma are not part of any screening panel. And in Ontario, a community doctor cannot order serum-free light chains.
Wow.
It is not paid for. Now, they could have the patient go and pay for it, but that's not how things are done. And that test is absolutely necessary to pick up 20% of patients. Even the electrophoresis is not a standard panel. And a busy family doctor may, I mean, all my patients have myeloma or related diseases, but a family doctor may only see 1 or 2 cases their whole career.
Yes.
So educating the community physician is a huge priority. And they are the first line of defense. They've got to be aware of all these diseases. I've spoken before physiotherapists and chiropractors. There are these organizations about what you have to worry about. So I think we just have to keep hammering away, but it is a challenge. Other provinces can order and get funding for these tests to be ordered in the community more easily, but that's only one of the challenges.
And I guess another thing that sort of I was just sort of thinking, you mentioned you had a patient in her 20s, and certainly in my time I had a number of patients in their 30s, but the majority of patients with a new myeloma diagnosis are, sort of my age, mid 60s and up, and let's face it, my back hurts and I'm tired all the time, and then all these things that come with aging, and I think when to maybe give some family physicians a little bit of credit, if they thought that every 65-year-old that went into their office and said, oh, I've been tired lately and my back hurts, they're certainly not going to jump like, oh my goodness, you must have some sort of a cancer diagnosis. So it would be great if we could spend some time talking with family physicians and helping them understand really what to look for. Slide, please. The diagnosis, I think all cancer diagnoses really do come out of the blue. I think as human beings, we always sort of have this in our brain that it's not going to happen. Nothing like this will ever happen to me. And as I mentioned, I come from a different area of oncology, and at least people with a colorectal cancer or a pancreatic cancer, they had heard of what that was. But many patients, I think, and maybe people in the audience will disagree with me, but I think that many people with a myeloma diagnosis in the beginning had never heard about multiple myeloma, didn't understand what it was. I had at least two people that I followed who had myeloma for a long time, and they both called it melanoma. So I mean, it isn't well known. Breast cancer has all the play in the community with pink tutus and walks and all of these fundraisers and I think it's getting better. I think that we are hearing, the public is hearing more about myeloma, but even though it's the second most common hematological cancer, it's still very, very rare. um my role in nursing, or my interest in nursing, right from the very, very beginning when I was a very young girl, was always about quality of life for patients with life-limiting or life-threatening diagnosis, because things just all of a sudden change on a dime. Younger patients especially are often so very concerned about their spouse and their children. They have questions: is this something that my children are going to inherit? Am I going to die before they get to grow up? Who's going to look after them? How am I going to pay my bills? Right now, they keep saying that this economic crisis is going to get better, but it seems to be getting worse. And to be a young person, or two young working parents with children, and wondering, when can I go back to work? And often I would hear, when am I going to be off of chemo? Not realizing that once we get the disease into a decent remission, that people generally do stay on treatment forever. And often, like any oncology diagnosis, people have a lot of guilt, and I think it's very important that clinicians really, really address this when patients are first diagnosed, that this is not something that they cause. This is not something that, I ate too much, or I drank too much, or I stayed up too late, or whatever the case may be, that we really, really, really need to support people, especially in the beginning when they have this shocking diagnosis. Slide, please.
So I'm going to go back a bit more to the science and talk about the tests that your healthcare team will be ordering to follow these tumor markers. The classic one is in the blood or the serum or in the urine what we call a protein electrophoresis. And this is the only test that can tell us the name of the monoclonal protein, and it can give it a number. But labs report it differently. One lab will say, well, the M spike is this, or the M protein is this, an older term, the paraprotein is this, the myeloma protein is this. But this is the test that will tell us what the isotype is, and it can measure it every visit. Now, there's another blood test that labs much prefer to do because it is easy to run through a machine. The electrophoresis requires some interpretation. And that's called the quantitative immunoglobulins. And I've already tried to explain that we have lots of antibodies in our blood that are directed against different invaders. And the quantitative immunoglobulins gives us the number of the total IgGs, kappa lambda, the total IgAs, and the total IgM, the most common classes. But it doesn't tell you how much is the tumor marker. And one can be fooled that if the IgG level total is 15 and one's patient has an IgG kappa, you don't know if that 15 is all good antibody or if it's all tumor marker. And I think most of the labs over the last 15 or 20 years have, been convinced that you can't substitute these in the ordinary situation. But again, myeloma is sneaky. There are some people with IgA myeloma, and you can see that the total IgA is only up to 3.5. That's not very high. Sometimes IgA is a tumor marker that's just hard to measure on electrophoresis. You don't get a precise value, and the lab will tell us, pardon me, it's really better to follow the quantitative IgA. But if you do that, you need to do it every visit. You don't go back between the electrophoresis and the IgA total. Next slide, please. I'm going to take it a little more complex because I think this serum-free light chain assay is really important, but it has some limitations. Again, you see the plasma cell on the left, and it's secreting its whole antibody and the extra light chains, which it always does. And the lambda light chains tend to pair up with their twins. And as I've said, plasma cells always make more light chains than heavy chains. And usually the light chains, whether they're good or bad, are broken down in the kidneys, and that's the end. But if the level's very high, they can overwhelm that and then spill in the urine. And in the old days, the only way to pick up excess light chains was to do a 24-hour urine and electrophoresis. Well, that's hard to do every month. But then you can measure them by the urine electrophoresis. The problems are that the free light chain assay, once again, can't tell you how many of that total kappa are coming from myeloma cells and how much are the normal background cells. And it is a very good test for picking up early slight rises in free light chain from the tumor clone before they spill in the urine. And it's certainly more convenient than doing a 24-hour urine. Now, there are other challenges. The FDA and Health Canada don't recognize following free light chains to approve a drug the first time for the market. So those trials that are trying to get a drug on the market often exclude individuals whose myeloma cells just make free light chains because it's not only the tumor marker. And that's very frustrating because, of course, an individual can't control what their myeloma cells make. And that's one of the things in our CMRG trials. We really consistently, we're not trying to get a drug on the market the first time. We're trying to make drugs better, less toxic, fit our Canadian population. but we have not excluded those patients. But this is one of the barriers to getting on some what we call registration trials to get some of the new drugs on the first time. Next slide, please. Now, another background of biology, and if you'll bear with me, there was really a landmark discovery 10 or 15 years ago that all patients who are diagnosed with myeloma go initially through a benign or precursor phase called MGUS, and that stands for monoclonal gammopathy of undetermined significance. That means an extra antibody, we don't know what it means. And I've shown that on this progression of pictures of a plasma cell over the red arrow. The first step that happens, and each of these steps has underlying changes in our normal chromosomes, and our genes are on our chromosomes. But the first step is a normal plasma cell becomes immortalized. It doesn't die off when its day is done. It's not behaving like a cancer, and there may not be too many extra of them, but it's immortalized. And depending on how many of these immortalized plasma cells are in the marrow, we either call it MGUS or smoldering myeloma. But the catch is it's not causing any harm. There are other genetic or chromosome events that then can happen, not in most people with MGUS though. MGUS is very common. It's 2% of everyone over age 50 and 5% of everyone over age 70. If you go looking, you may find a small extra antibody. But if there are other events that happen, then the disease becomes a cancer, malignant transformation. The term intramedullary myeloma, I think of as that's just our typical myeloma when the disease stays in the bone marrow. But with further relapses, the disease can get smarter, it can get more aggressive, and in some situations, it leaves the confines of the bone marrow, becomes extramedullary, and it can go other places. And this is not a good phase to have, and it's the subject of particular drug development. Now, we've been trying to study the chromosomes and genes in myeloma and unlock the secrets for quite a while. And older slides looked at all the chromosomes in a plasma cell and tried to figure out what's going wrong. That's the karyotype. Nowadays, we use a more sensitive test called FISH to look at our chromosomes. I'm going to show you some pictures just to give you a visualization of when these tests are done, when you contribute your bone marrow for diagnosis and study. This is the kind of test that's done. Next slide, please. Actually, I will inflict upon you a little bit more information about the genetic changes because you may have been told this about your myeloma by your physician. So I've shown at the top here those phases of normal plasma cells, MGUS, smoldering, multiple myeloma. So by the MGUS or immortalization phase, the primary genetic events have already occurred. And there's two main classes. Either one can lead to an immortalized plasma cell. About half of patients, there's an exchange of genetic material between chromosome 14 and another partner. And you can see the common partners at the bottom left, translocation 1114, 414, and 1460. Then as the disease becomes more dangerous, more causing more symptoms, there are what we call secondary events. Some of them more common are the 17p deletion. We're now recognizing chromosome 1 changes. Now, we have been, I think, able to convince over the last 5 to 8 years, really most labs across the country will do these basic abnormalities. There is classification. 414 is said to be high risk, 17p is said to be high risk, but this is imprecise, and I may be able to share this with you at some time. It's the minority of people with 414 and 17p that really have high risk disease. We now know there are better genetic tests to distinguish who really has high risk 17p from who doesn't have high risk. So this is a subject near and dear to my heart, because scaring people unnecessarily, meaning well, by telling them they have high risk disease, when we're going to learn in later years, well, it wasn't quite that bad, or missing high risk disease and reassuring people and have the disease come back earlier. That's not how we want to take care of people. Next slide, please. So here's the pictures I promised you. The one on the gray just shows all 23 pairs of chromosomes lined up from a myeloma cell. And you try to see, they stain it and see if those little bands match up on the chromosomes. And it's not good enough. But that's all we had when I first came to Toronto. We can now make a slide of plasma cells, like at the top there, and then stain it with fluorescent probes for these different abnormalities. And we can screen 100 or 200 cells now. And I don't have a pointer, but this is staining for chromosome 4 and chromosome 14. One is red, one is green. They should be separate. But if you notice in the top left cell, the red and the green are side by side. They shouldn't be. That's a translocation. So we can say these myeloma cells have that abnormality, which I think is kind of cool compared to where we were. Next slide, please. Okay, Suzanne's going to take it away in a minute, but I'm going to inflict one more biology, because this information, I think, has really helped me understand, when I've seen a patient in clinic, what might be coming on. Myeloma can change during the course of the disease. Doesn't go from IgA to IgG, but at relapse, the myeloma cells may forget how to make the heavy chain. So we pick up a recurrence only with the light chain going up, the light chain escape. That's why we check it every visit. In some patients, their myeloma forgets to make any monoclonal antibody. And we have to, if we don't know what's going on, we need to do a bone marrow and see what's going on with those myeloma cells. I've already talked about extramedullary disease. If large numbers of myeloma cells go in the bloodstream, we call it plasma cell leukemia. That just means bad cells in the bloodstream. It can go in the central nervous system, or the term plasmacytoma just means a lump of myeloma cells, and it can go anywhere. Now, another feature that I think explains a lot of what we observe in clinic is at diagnosis, myeloma patients have what we call 5 to 7 subclones of their myeloma. They may be in different spots of the marrow. They're all part of the same cancer, but there may be slight differences in them. Maybe one just makes light chains. Maybe one has an extra mutation. And I've tried to show the course of one patient's proportion of these different subclones with that circle. And you can see at the beginning, most of the myeloma cells were of that dark orange form, but then after treatment, it was the light orange that came up. So relapse is usually due to 1 or 2 clones that start growing. And this explains why, except if we have to hold treatment for a washout to go on a trial, we don't change treatment until we know exactly what someone's going to get. Because not everyone, but if we stop treatment, even though we see that it's not working, that treatment could still be controlling 4 of those subclones. And if you stop it, they wake up too, and the disease can escalate. Now, you don't see this in leukemia, you don't see this in lymphoma, but it also is the reason we use several drugs to try to get all these subclones. And they can come and go. This was discovered to be the case in many patients, actually by a Canadian way up in northern BC, who now is a hot shot in the States. Next slide, please.
Now, I'm very cognizant of time. There's so much information about myeloma that I'm going to sort of just go quickly. We talked a little bit earlier about what people experience upon diagnosis, and this slide just lends to that, things that people may find that they are experiencing when they are first diagnosed. I always say that myeloma loves bones and kidneys, and we'll certainly take some time in future seminars to talk about this at greater length. But I'm very cognizant of the time. People might have some questions. Slides, please. I will take a minute, though, to say that, Dr. Reece has eloquently gone through all of the things that are happening in a patient's body, all of the science that's going on, all of it's a really, really complicated disease. And that being said, regardless of where a patient is in their trajectory, they will need supportive care at some point. And we have many, many tools at our in our arsenal, if you may, to combat things like pain. I could do a whole 2-hour talk on just pain management in myeloma. When we see patients and we're doing blood work, whether it's weekly or monthly, there's a number of things that we're looking for. Is the patient anemic? Do they have too much calcium in their bloodstream? Are there any signs of infection? And then we act accordingly. We've all just come through a very, very difficult time in the world with the pandemic. We know how infections can be life-threatening even to well people with no comorbidities. It's absolutely imperative that patients with myeloma and their loved ones are all up to date on their vaccinations, including their annual flu shot, our COVID vaccines that Health Canada is recommending. Things are always in play there. I just heard there's something coming up very soon. But again, and for those of us that are, of a certain age, we want to make sure that we have the pneumonia vaccine as well. But again, due to time limitations, we'll talk about this all at on another day's slide, please.
I have to apologize. I think I got carried away, Suzanne. And,
it's okay. It's okay. We just want to have time for questions. We don't want to go over.
Yeah. Well, I could talk forever, and
as could I.
But we're not going to go over specific regimens or treatments today. But I think it is important to at least have a framework of the different drug classes. And I've just listed them on this slide because our treatments are combinations of these. And whether someone's disease is sensitive or what we call refractory, it means it's grown through a drug or a drug class, is having increasing relevance to what an individual is going to be able to receive later on by funding or eligibility, et cetera, et cetera. Next slide, please. So I'm just going to talk about some principles of therapy. Right now, improving myeloma outcomes still depends on the use of combinations of these drugs, milking each line of treatment for all it's worth until it quits working in sequences. And each of those lines, each of those treatments or regimens has the goals of control the myeloma burden, suppress the disease problems as long as possible, but maintain the quality of life. And I've already mentioned we need several drugs with different modes of attack on the myeloma cells to take care of all these mutations and abnormalities. A big advance has been the use of daratumumab or isatuximab, these anti-CD38 antibodies. And really every trial has shown that 3 drugs, what we call triplets, work better and longer than doublets. And one of those agents right now has been steroids, dexamethasone, sometimes prednisone. Quadruplets, 4 drugs, are increasingly considered and become the standard of care in the US and parts of Europe. And so that means that instead of getting these different classes with 3 lines of treatment, patients are getting all of them with 1 or 2 lines, exposed to them early in the disease course, and may be becoming resistant to them. So I wanted to make our audience aware of this change that we have classified measuring how much exposure someone has had to the different drugs by describing a line of treatment. And a line is defined as at least 1 cycle of 1 drug or combination. But what also is a line is a planned sequence. So getting induction like Cybor-D, a transplant, and maintenance is 1 line of treatment. Well, 1 line could either be getting Rev-Dex or all that transplant. So it's really not very accurate. And some of the new drug approvals, and for instance in the US for some of these new immune drugs, you have to have 4 lines of therapy to get eligible for certain CAR T and stuff. Well, what if someone's had all the classes with 1 or 2 lines? So one of the things we're doing at CMRG is really pushing through our analyses and our database results that we need to look at drug exposure, how many drug classes and drugs, and whether the disease is still sensitive or refractory. So I think you'll see a shift in that. Next slide, please. One of the problems or challenges is that all studies so far have shown that given continuous drugs work better than fixed duration approaches. You may get the same survival by taking some breaks, but using the example of lenalidomide maintenance, that's the only time someone can be on 1 drug at a low dose. And yes, you know, when the disease comes back, it may be 3 or 4 drugs given intravenously. And actually, most agents were developed to be given until they quit working. Lenalidomide, Revlimid, pomalidomide, carfilzomib, the antibodies. And that means when we quit using them, the disease is usually refractory. Now, there are clearly people that can stop treatment and have a relatively unmaintained remission. The big problem is we don't know who those people are. And by stopping treatment, we're taking a calculated risk that it's going to be okay, but we also don't know what clone's going to come back. Is it going to be an evil subclone, or is it going to be one that's grumbling along? So just having a deep remission doesn't define that you can stop treatment. We're working on it, but it is a challenge. Now, there is some good news on the horizon. You know, continuous treatment is a burden. CAR T, though, is 1 treatment. It's not curative in myeloma at this point, but it is right now given to provide a treatment-free interval. The bispecific antibodies that have just been approved have been studied to be given continuously, but I think many of us in the field believe, and this is not unique to us in Canada, that this may be a good strategy to have fixed duration. And actually our CMRG trials we're trying to negotiate will look at fixed duration, not giving these indefinitely, because they do suppress the immune system a great deal. I don't have time to give you all the different database results we've generated, but one of these analyses we did, we were able to feed back to Health Canada and to CATA that we really need these new drugs. You know, there's been data in other countries that, oh, you know, half of people only get one line of treatment and then they can't get any more. Well, we looked at our data in 2,500 people. And if you look at those who'd had a transplant or not a transplant, after the first line, even in the older, more frail people, the vast majority of people need second line, go to second line, even third line. So we need these fourth line drugs, these CAR T, these bispecific, because our patients need these new drugs. So we've been able to really make that argument, you know, keep it coming. Next slide, please.
Again, really want to thank those of you in the audience. We would, Dr. Reece and myself and the rest of the team at CMRG, we really want to thank Myeloma Canada for disseminating the information about this evening's event. We're very grateful. We do plan a series of, it really should say at least 7 more seminars, as it's very obvious that both Dr. Reece and myself and the rest of the team, we're very passionate about this, about myeloma and the care of the patient and all the important research that's being done. Some of the upcoming topics that we have talked about, things like interpretation of tests and understanding blood work, an evening talking about pain and how to manage symptoms, current treatment options that are available now, and what's coming down the pipe, new immune options, etc. And a night, maybe an evening on clinical trials and access programs. We would really like to hear from you in the audience. We want to know what patients want to talk about, what you want to hear about. It might be that you would like an evening where the floor is open to discuss not your disease specifically, but questions, general questions about myeloma, etc. We have a few minutes that we can maybe take some questions this evening, but if we can't get to you, please email Lydia at her email there is at the bottom of this slide, and any ideas that you have about upcoming seminars, you can certainly email. Now, Jeff has just raised his hand. Jeff, you have a question or a thought? Hi, Jeff. Jeff, you're muted. Letty, are you able to unmute Jeff? And Robert has a question and Jeff has a question. Jeff, unfortunately, we can't seem to hear you.
Let me see. They can all unmute themselves.
Jeff, can you unmute yourself? Just down there on the left-hand bottom of your screen, you can click on your little microphone. It should unmute. Maybe we'll go to Robert Wilson first while Jeff figures out how to unmute himself. Robert, go ahead.
So thank you for this seminar, Dr. Reece. I wanted to ask, what is the current availability of CAR T, and is there an age limit?
I'll do the easy part first. There really isn't an age limit. Even though there is some moderately high dose chemo that's given, kind of like a stem cell transplant, but not quite as harsh, to suppress the immune system so that these re-engineered cells can have an advantage. Right now, there is one trial that offers CAR T for people with relapse disease. The trials, other trials are just in earlier stage. That's where the pharma's going. And this trial is only done in Toronto, and it's going to end next month. So I worry about the gap until cilta-cel is funded. I mean, everyone's pushed for this. Our CMRG, we report our feedback to CADIF as a group. We get lots of docs to sign a consensus statement. But you know, it's a $500,000 for the CAR T product, and it's $500,000 for the supportive care.
Where is
So-
got a question?
So
Can you read
we
that?
need it desperate. There's also a production problem.
Prophylaxis of dexamethasone.
So, it's hard for an access program. Access programs have traditionally, the drug companies given us the drug, but now where are we supposed to come up with the other $500,000 in the hospital to take care of the patient? So it's easy for a drug company to give lenalidomide free. There's no mixing, but to give a CAR T, they just give the drug? Where are we going to get the rest of the money, even for compassionate programs? So if cilta-cel gets funded quickly, we'll be in better shape. But I think we're all pushing. I hope that answers the question.
Sorry, I'm gonna, Jeff, you're still muted. Jeff, if you have a question, you can put it.
I'm here now.
Oh, there you are.
Yeah,
Hello. Go ahead.
Thank you for having this seminar. It was fantastic. My wife has a question. Her name's May.
Hi, Donna. Hi, Suzanne. Thank you so much for hosting. This has been very, very informative, and
Hi, May.
It really is helpful. I appreciate it. We appreciate it. Just to piggyback off Robert's question, is basically we were informed by the oncologist that once you pass up a clinical trial, you wouldn't be able to qualify for any upcoming ones. Is that just based on the fact that he's already began a different treatment or a different approach, and would he qualify down the road if remission wasn't successful, or if he does go into remission and then it comes back, would he then qualify for a clinical trial?
Well, I would say trials have eligibility criteria, and the vast majority now, the disease has to be growing. They're not going to treat when the disease is under control. And many times the disease has to be at a certain level because pharma wants to be able to make sure the numbers went down to tell the FDA that it really worked. So if the M spike is 2, how are you going to prove that it worked? It's already too low. So in a way, an opportunity is missed but when the disease comes back again, depending on what trials are open at that particular center, there might be the opportunity. But, centers, pharma doesn't give every trial to every center in Canada. There may just be 1 or 2 with one trial, or, Montreal might have a trial and we might have a trial and Calgary might, and trials open and close. So when they reach their target, 200 people, it closes. So we're always trying to jiggle with the patient's disease. Is something going to be open when they need it? I don't think because a trial is refused at one point, that doesn't mean automatically you can never get another trial. But some trials say, well, you can only have 2 treatments. Some say you have to have 4. Some say your platelets have to be this. So the eligibility criteria are key to getting on a trial. And the center has it open.
And Donna, who would be the best resource to find out? I mean, I guess it would be your oncologist to determine whether or not you'd be eligible for these clinical trials. How do you self-advocate for something like that?
I think you really have to go through your physician and find out what's open in your center. And one of the reasons we wanted to do these seminars is for these new bispecifics, they're going to be access programs, and something odd is going to, I think, different hospitals may be able to eat the cost of the supportive care because the funding isn't going to come from the healthcare system for the needs that have. For most bispecifics, you have so many days in hospital. Well, that's a new reason to go to the hospital, and the hospital has to pay for antibiotics and the antidote to CRS. Those would be covered by the government if the drug was funded. Now, all of a sudden, the hospital pharmacies are supposed to put that money in. So some hospitals say, yeah, I can treat 2 people a year. Princess Margaret says, my gosh, we have, 25 people now that need this. We don't have the budget to put everybody in so many days and give them all their supportive care. So it's going to be hospital by hospital for these access. And we hope to get some information by the time that comes up on this lecture series. Where might you be able to go? And it's not even all worked out yet with the 2 bites on the horizon. But we want you all to have that information.
Michael, we'll get to your question in just a second, Michael. We have had something in the chat box for a few minutes now. Gabrielle, his question is carfilzomib stopped after 18 cycles in the KRD regimen? Is it best to continue? I'll give that to you, Dr. Reece.
That's a good question. That was the first carfilzomib combination trial. And they wrote it to give it 18 cycles and then just continue the lenalidomide, the Revlimid. I don't know if it would be any better, but one challenge with the way KRD was given is it was 6 doses of K a month. That's a huge burden. Now we're moved to giving it weekly rather than twice a week, but I don't think we know the answer to that. Most of the time, there are regimens that we would like to continue all 3 drugs instead of drop back to 1 or 2 because this principle, and again, some people you can get away with tapering it down and some you can't. You just don't know who yet.
Thank you. Go ahead, Michael. You've had your hand up for a few minutes now.
Oh, that's okay. And my wife has got a question for you.
Yes. Hello.
I am Jackie Maso, and I really appreciate what you just about that seminar. I've learned quite a lot here. Thank you so much. But I've got a question there, which I'm Mark on the what is PEEP prophylaxis of dexamethasone? What does that mean?
What prophylaxis? I'm sorry.
Of Decadron.
What do we use Decadron as to prophylax with?
Yeah, what's a PEEP mean? PEEP prophylaxis.
Yeah. Some of our newer drugs, particularly the antibodies, like daratumumab, Darzalex, Sarclisa, or isatuximab, can cause fever and chills as a side reaction. They're actually antibodies. Now, which just blows my mind because what's the tumor marker in myeloma? It's an antibody. These drugs are actually monoclonal antibodies made in the lab where they're engineered not to stick on a germ, but to stick on a myeloma cell. But they're protein antibodies. So when they go in us, particularly the first dose or 2, they can cause fever and chills. And you can help prevent that with Decadron.
Because Mike has been on it for 4 years or so.
Yeah.
And the doctor just reduced it and
well, we're not off of it.
We got going to be off it. Is that a good thing?
It depends. We like to reduce the dose of Decadron if we can, but it also kills myeloma cells. So it is part of the treatment. I was thinking more when you're giving it prophylactically, it's used in other cancer treatments that are antibodies for other diseases. But most of our drugs for myeloma work better with some steroid like Decadron. But we may reduce it a bit over the years, cautiously, because all our drugs have side effects. But I was going to make one point, one challenge with stopping treatment and taking a break is if someone has high blood pressure and they stop their meds and the blood pressure goes up, the doctor just puts you back on the meds, the blood pressure comes down. Yeah. Myeloma is sneaky. If you stop the medicines, it's going to grow back. It's probably going to grow back sooner than it would if you continued the drugs. The catch is you may start back what you were on, but it may not work.
But
It's best to carry on.
yeah, but don't be alarmed. I'm sure if your hematologist, your doctor, there's many reasons, and I'm sure Dr. Reece would agree, there's many reasons that we might pull back a little bit on the dexamethasone, because I mean it does have, it's usually not the so-called chemo that gives myeloma patients the hardest run for their money. It's often the steroids. So don't be too worried that because they've reduced the doctors reduce the amount of steroid that, you know, the disease is going to explode. You know, next time you go into clinic, take your, you know, write it down, because I know whenever I go into clinic, I forget what I was going to say, and say, we really want to understand why this has been reduced, and I'm sure that give you a good answer. Now, Mary has had her hand up for a bit, and then it'll be Geraldine, and then it'll be Shijing. Yeah.
Well, thank you very much indeed. That really helped a lot. Thank you.
You're more than welcome.
Thank you.
Go ahead, Mary.
Hi. Yeah, thank you so much for the
Mary,
seminar. It's been
have
very, very valuable. I think my question has kind of been answered. With the maintenance dose after stem cell, the lenalidomide, if it's having bad side effects, and the suggestion is to reduce the dose, how much does that increase your risk? Or can you even say, given everybody's different? I mean, it's all a juggling act, but that's kind of where I am right now.
Yeah. I mean, there's that goals of treatment, control the disease with a good quality of life. And we've done studies at Princess Margaret and CMRG. You don't need 15 milligrams a day of maintenance like in some of the US trials to get the good results. And I won't go into the project we did at Princess Margaret a number of years ago that no one wanted to publish, that showed that low doses can do the trick. Now, we don't know the lowest dose for everyone. Again, there's unpredictability. But in my practice, I think it's so important to go with a dose people can live with. And in this study we did, and again, you have to go what your doctor says. I don't want to be misleading. You know, we found that people that were on quite low doses seemed to benefit.
Like
so, I mean, I go down to 5 milligrams every other day if that's what it takes for quality of life. But again, you can never predict for certain what will happen. Maybe we'll have better markers. And I don't want to leave people with the idea that dose reduction can't be done, that it's, you know, like about the steroids. You have to preserve quality of life and safety. And I was talking, you know, more about when what we call fixed duration treatment, like some of the older treatments, you give 8 cycles and that's it. That's what you do for lymphoma. That's what you do for leukemia. You give X cycles, no matter what, then you stop. Adjusting the dose for quality of life. In some studies, you know, staying on a dose that's lower is actually better. Or occasionally there's a study that says dropping the steroids may, as long as you continue something else, is in the long run better because you can stay on the regimen.
Yeah. Okay. Thank you.
Go ahead, Geraldine.
Yeah, my question is along the same lines. I'm on the Revlimid after post-stem cell transplant, and I've been on the Revlimid for about 5 years now. My quality of life is good, but I'm neutropenic, so we've had to lower the dose from 10 to 5 and then sometimes down to 2. And I guess my question is, rather than lowering the dose and stopping it, wouldn't it not make sense to get Grastafil shots instead?
Well, we can't really go into your particular case. I think when you go back to the, you know, I think that'd be inappropriate or misleading. But in general, when the trials were done for Revlimid maintenance, the trial gave the option of dose adjusting or using Grestafil. So it's sort of either or and individualized.
Okay, thank you.
Shijing, I hope I'm saying your name correctly. Go ahead.
Yes, very correctly.
Oh, thank you.
So just first half at the beginning, I found it very difficult to follow because it's a lot of data and science and then
Yes,
the things, and maybe English is not my mother language, so I have a little bit of problem to understand. So I realized that this is recorded, so I would like to know how to get the reach of the recordings.
absolutely. And Lydia can let you know how to, I believe, get access to the recording. And thank you for bringing that up. We're going to have many of these talks, and some will certainly be more scientific than others. I'm not the science guy by any means, but thank you for reminding us that that we have people in the audience that don't have English as their first language, and if there's once you go through the recording, if there's anything that you certainly just don't quite yet understand, please email Lydia and either Dr. Reece or myself. We can get back to you and sort of just finesse it down to make sure that you sort of got it. We're more than happy to do that.
All right, thank you very much.
You're welcome.
I wouldn't apologize. I speak one language and it's embarrassing. Canada's full of people that speak 2, 3 languages.
Absolutely. Well, it's now 6:17. There's no other questions in the chat, and we don't have any further hands up. Again, always cognizant of people's time, and for some people in Ontario, it's dinner time. I'll let Dr. Reece rather and Lydia close down the evening. Once again, I want to thank. I want to really thank the people at CMRG for allowing me to volunteer my time in my retirement, and really, as I mentioned, it's for me, it's all about quality of life. We were talking about patients had questions about, I'm not tolerating the Revlimid, or that they've had to reduce my dexamethasone, and for it's so important that patients have a good quality of life, and that we manage these symptoms very well. And we will have future talks about how to best manage these symptoms so that patients can go on and have a fabulous life, even though they have multiple myeloma.
Well, I think just to echo that, our CMRG trials really do try to minimize drugs as long as we can do things safely. I mean, we piloted one of the first groups to pilot a trial that gave carfilzomib once a week instead of 3 times a month instead of 6 times a month. I mean, parking at Princess Margaret's $27. If you can even get downtown, I mean, that's so. I mean, it's definitely part of all of our clinical trials is how to Canadianize things. Use pills when we don't, rather than intravenous, and sub-Q rather than long IV infusions. When we put this list of seminars together, we sat down and brainstormed what we wanted to talk about. But I think as Suzanne and I prepared these slides, we thought, well, maybe you all have different questions and priorities. So we probably will rejig. We have some flexibility. We wanted this to be casual, as casual as we could under the format. But again, we would welcome, topics that really are important to you. Tentatively, we're going to do the next seminar also Thursday this time. Letty, it's October 12th.
Yes, it will be October 12th. The time is not confirmed yet, but most probably it will be at the same time, 5 p.m. to 6 p.m.
So we will post it on our CMRG website when it's finalized. We want to
And
make.
we'll email everyone.
Oh,
about
okay.
The seminar, yeah, the second seminar, yeah.
Okay. Well, thank you everyone for your attention. You know, there's so much going on. It's almost hard to keep. It is hard to keep track of. And we have our big International Myeloma Society meeting in Athens in just a couple of weeks. So there'll be a whole nother wave of data coming out. And actually we have a couple of CMRG posters there too. So we're getting on the international stage with our analyses. You know, all countries have had government supported clinical trial groups. We're not government supported. So, you know, we want to get drugs to patients. Good drugs, good regimens, and have good data to show the funders, Health Canada, that highlights what we do in Canada, not what they do in the US, not what they do in Europe. They use a lot more thalidomide in Europe. They give long IV infusions in the US. It has to do with the way the healthcare system's set up, but we want to Canadianize things. So again, I could talk forever. Thank you very much. Suzanne, are you going to give me the hook?
No. I just wanted to make sure, Shijing, if you go ahead and email Lydia, she can let you know how to get the recording. Okay, I just want to make sure that you get that and that you have time to go through it again. Well, we've still got 42 people online. I goodness knows, one of my questions to everybody in the audience is an hour long enough? We tend to do presentations for no more than an hour because people tend to get bored. But this is a population of people that doesn't, you know, you don't tend to get bored because you know, you want to learn more and more and more. So you let us know.
Thank you so much, everyone, for your
All right.
attention. Have a good night.
Good night.
Good night.
Good night.